Thank you, everyone, for joining us today for our webinar on individual intelligence and adaptive testing with Dr. Dunham. A few housekeeping items before I turn this over to him. Your lines have been muted upon entry, so that will not afford the opportunity for you to ask questions via that channel, via auditory, but you can ask questions using the chat box. So when you submit those questions using the chat box, we ask that you submit those to, at a minimum, panelists. You just send those to the host. I'm going to be the only one that sees them, and I promise you I will not do the answer the justice it deserves. So submit questions via the chat box to panelists or all attendees. Either way will be fine. The second piece is this webinar is recorded. So if there are others that you believe that would be able to benefit from this information that were unable to attend, we will post this recording on our website, and the division email blast will go out when that is available. And with that, I am going to turn it over to Dr. Dunham.
Thank you very much, Heike. First of all, it's my pleasure to be with you today. It's always enjoyable for me to get back to Missouri. Went to school here back in the 90s at Mizzou, and I really fell in love with the place, and I get back to Missouri every chance I get. I started working as a school psychologist in Louisiana back in the mid-'80s, and then moved to Missouri and worked here for several years, and then I've been at Murray State University in Western Kentucky since 1997. So I started a school psychology program down there. And we have quite a few graduates that wind up in Illinois, some in Missouri, a lot in Tennessee, a lot in Kentucky. But what I wanted to discuss today were issues around individual intelligence and adaptive behavior testing, things that I have worked with for years. Like any test, there's strengths and then there's weaknesses to these things as well. So idle planned, this is Friday. I should have you out of here by, 7:30 or so. Not really. So purpose of the workshop here is to review assessment concepts and then test interpretation. So that's going to be probably the biggest, our biggest focus. So from an ethical standpoint, just a caveat, I'm not going to be able to answer any specific case questions or any DD or waiver eligibility questions, but I do invite you through the chat to ask questions, and then hopefully we'll be able to get to those. We'll also look at distinctions between screening and diagnostic tests. We'll review, discuss IQ, adaptive, and some achievement testing concepts and their purposes. And then we'll look at just a handful of case studies here. So the first thing I kind of want to point out here is phrenology. I think most of you have probably been a little familiar with this, but phrenologists were people that they called themselves mental health practitioners, and the idea was, of course, this was back in the mid to late 1800s, they would actually palpate the sides of the person's head to feel for different bumps and fissures and so forth. And the idea was that they could interpret or analyze a person's personality based on the contours of their head. Of course, this was completely goofy, but at the time it was considered state of the art. I don't know about you, but frankly, my head doesn't have that many. It's more smooth than anything else. But if you look at this sample phrenologist or this rendition here, for example, if you had a large bump toward the occipital on the back of your head, and that was indicated that you had a lot of self-esteem, and a certain type of bump up toward your frontal lobe over your eye area, then you were a witty person. But obviously, the problem associated with this is that it's completely open to interpretation. So there was nothing about it that was scientific whatsoever. And so this kind of brings us to where we want to be with our tests. And so what we'll talk about first here is going to be several important concepts I want to go through. The first one is the difference between a criterion reference test and a norm referenced test. So a criterion reference test, they tend to measure a very narrow band of skills versus a norm reference test, and we're going to talk about what that is here in a minute. Norm reference test measures much more a broader spectrum aspect of functioning. Criterion reference test, there's many items, but again, they're only measuring a narrow band of ability. Broad spectrum, there's fewer items. The purpose is different between these. So a criterion reference test is primarily instructional, academic for academic instruction, and a norm reference test is best used for diagnostic purposes and for eligibility to access services. An important difference between the criterion reference test and the norm reference is the interpretation. So with a criterion reference test, you interpret the person's skills based on the percentage of the criterion that they actually got correct. A norm reference test, you look at where that person's score falls within that normative group. So we can't find an example here. So, for example, let's say that Bob has mastered 83% of his times tables through number 10. So that would be a criterion referenced measure. Here the criterion is timetables. And notice that the index is that 83%. He has 83% mastery. It's a criterion reference. Now, this next piece here, Bob's performance on the Woodcock-Johnson Achievement Test placed him at the 53rd percentile. That's a norm referenced test. Okay? So again, this 83% of his timetables, that's used for instructional purposes. And this next bullet here with the Woodcock-Johnson, that's where we are comparing him to other people his age. And that's used for diagnostic purposes, used for eligibility to receive specially designed instruction. So a percentile tells us the percent of people who took the same test as Bob who scored at or below that score. So for Bob, that 53 percentile, that means he scored as well as or better than 53% of other people his age, okay? So an important distinction between these two tests, criterion and norm reference, is what the anchor point is. So the anchor point for the criterion tests are the test items themselves. If it's addition, if it's word recognition, if it's spelling. The anchor point for a norm reference test is the population of other people that took that same test, okay? Now, we'll pull this together. It's harder to do this without a lot of graphics, but I think we can illustrate this as we go. So norm reference tests, we use them, we say standardized tests. We use these two words interchangeably often. So they're used for diagnostic and eligibility purposes. This is to make a diagnosis, for example, of an intellectual disability or of a learning disability. And to determine eligibility for special educational services, for gifted programming, for example. So our norm reference tests, those can be academic, they can be personality measures, they can be intellectual measures, and they can be adaptive or independent functioning measures. Now, diagnostic tests, or our norm reference tests, those tend to have several scales. They have several indices and not just one. So, for example, a measure of intellectual functioning will have an index that measures verbal ability or verbal reasoning, an index that measures visual spatial thinking, an index that measures decision-making speed. So our diagnostic tests, what's nice about those is that it gives us a number of different scores that we can interpret to give us some sense about why the person might be struggling in school or on the job. So our norm reference test, the individual items for each scale, they start off very easy, and then they advance to very difficult. So typically our diagnostic tests may have 8 or 10 individual scales. Each of those scales has maybe 30 items on it. Item 1 is very easy to pass. Item 30 is very difficult to pass. So the number of items that a person actually gets correct is called the raw score. So there's several important concepts that we're going to be going through. We've talked about criterion referenced, talked about norm referenced, and we're talking about raw scores. Okay, now by themselves, they don't tell us much. But we can anchor those. We can anchor those to what is considered to be average, and that gives us a way of interpreting where this person's functioning or skill level is falling compared to other people their age. So, for example, the fewer items one gets correct, the lower their reading skills, IQ or memory, problem solving, whatever. The more items that they get correct, the higher their skill level relative to other people their age. So that raw score, for it to be meaningful, we have to anchor it to what the expectations are for other people that person's age. So now we're converting that raw score to what's called a standard score. And this is where the normal curve comes in. One other point, standardized means that that test is administered the same way to every person. So when I'm teaching students to administer IQ tests or achievement tests, I have to make certain that my students are administering this test in the identical way to every person that they are working with. So let's look at the normal curve here. So this is a copy that I pulled out of some book several years ago, but the idea is if you look at the horizontal axis, that scores. So all the way on the left, those are low scores, starting with a Wechsler IQ of 40, going all the way up to a Wechsler IQ of 160 at the other end. So that horizontal axis that's the scores. Now, your vertical axis, that's the number of people that have those scores. So what you can see is that for all tests, all norm-referenced tests, it's personality, reading, behavior, intelligence, they're bunched up around the middle, around the mean. That's what the mean is, okay? So a normal curve, this is when the mean, median, and the median score are all, they're all the same, okay? Now we'll get through some of this boring stuff here, and then we'll talk about the application here in a minute. So the normal curve, this is it's a mathematical construct that undergirds everything that we do in mental measurement. So this normal curve is used to tell us where a person's raw score is falling compared to other people their age. If we have their standard score, then we know where we can place them relative to other people their age. I'm going to go back here just for a second to this normal curve. If we look at I don't know if you can see my cursor or not here, but normal is considered right at 100 or average. 85 to 115 is generally considered average on a Wechsler. Well, a Wechsler IQ is 90 to 109. But we define aberrant behavior or pathology, or we make diagnostic decisions based on how far from the average a person's score falls. So if a person is falling on the tails of this normal curve, then this tells us that there's very, very few people that actually have a similar score, just a very small percent. Most people fall, obviously, right in the middle, around the average. So, is that? Okay, let's talk about the mean and standard deviation. So these two statistical concepts are used in conjunction. Okay, so the mean is just your arithmetic average. Take the number of scores and add them together, divide that by the number of scores, and that gives you what the average is. So we all learned how to do that years ago in middle school. The standard deviation is an index of how much dispersion that we see in the normal curve, okay? It tells us how scores are distributed across a population of test takers. Now, let's take the example of archery, okay? So we'll try to do this without any visuals here. So if you take a bullseye, you know what a bullseye looks like. And you take a bow and you shoot at the bullseye at 25 yards. You do that 50 times. Well, if you're a decent archer, you should be able to hit, most of the time, should be around the bullseye. But sometimes you're going to be shooting to the right, sometimes shooting to the left, sometimes high, sometimes low. But the bulk of those shots are going to be in the bullseye. Now, what's nice about the standard deviation is that it's predictable. So for the archer, any hole that you placed in that target that doesn't fall right on the bullseye, that's just considered dispersion. That's just error associated with the testing. That's the error associated with the archer, okay? So that's that dispersion that is normal and it's predictable. When it's normal and predictable, then we're able to use that in conjunction with the mean to get some sense about how uncommon a score is that we may be obtaining. So derived scores or standard scores, these are often called deviation IQ scores. They've been transformed to have a specific mean and a set standard deviation. So for IQ testing, most achievement tests, personality measures, their average is 100. And most of them have a standard deviation of 15 points. Almost all tests have a mean of 100, standard deviation of 15. Now, this is helpful because it allows us to compare scores. So it allows us to take a person's reading comprehension score, their standard score, and compare it back to their IQ test score. So both tests are normed. The achievement test is normed. The IQ test is normed. So we have a person who has an IQ of 100, but their reading comprehension score is 80. That tells us that that there's a discrepancy between those. Usually those two scores should be within 12 or 15 points, okay? Okay, so I'm looking at the chat here. Okay, how are normative groups determined? How broad are the sampling? Excellent question. So some tests, especially older tests from the 60s, perhaps they would only sample a few hundred people. The old lighter international performance tests from the 40s, they only sampled a few hundred people just from Hawaii. But the test was distributed and people bought it. Now, a test company could not get away with that. So typically, the tests that we use today and the ones that we've used over the past 4 decades or so, they have thousands of people that have been included in that standardization sample. So for each age range, there may be 200 to 300 people, and they're given the same test, and then that way they establish their standard scores based on what the mean is for that age. Looks like one of the questions, the Stanford-Binet used to be a standard deviation of 10. Now the standard deviation of the Stanford-Binet back in the 60s and 70s was 16. And so the Wechsler scale, the standard deviation has always been 15. Now with the current Stanford-Binet, the standard deviation is 15 points. Okay, good. Good questions. Please keep them coming. So we talked about standard scores. Let me see here, make sure I'm getting on the right. There we go. So here's the stuff that I've bolded here are things that are very important. These are the things that I really want to make sure that you take away from this. So a standardized norm reference test have an average score of 100 and a standard deviation of 15. Every test on the market, with a few exceptions, they have a standard mean of 100, standard deviation of 15. There are some personality tests that use a mean of 50 and a standard deviation of 10, but that's a T scale. Okay, this is important to your scores. 90 to 109 are considered average for most IQ and achievement tests. So the Wechsler scales, 90 to 109 is considered average. That captures the middle 50% of the population, okay? Now the Woodcock-Johnson cognitive and the WJ achievement, average scores are 90 to 110, but it still captures the middle 50%, okay? So this corresponds to percentile ranks that are 25 to 75. Now, sometimes if you're working in schools, you'll have a parent or even a colleague that will come up to you and they're completely out of sorts because they have a child whose percentile rank is 32. They're freaking out because they know that a perfectly average percentile rank is 50, but he's got a 32. Well, a 32 percentile rank is still solidly average. It's still within that middle 50% of the population. So percentile ranks are often misinterpreted by folks, and it's easy to understand why, because 25 sounds awfully low, but still that's average. The bulk of the children that I see in public schools and in my private practice, their intellectual ability and their achievement scores are somewhere between the first percentile and the 7th or 8th percentile. So compared to others their age, more than 90% of the population is actually scoring higher than they do. Now, there's some tests on the market. The Kaufman test, for example, scores 85 to 115 are considered average. This captures the middle 68% of the population. So this covers percentile ranks 15 to 85. Okay. Now, this is another important component here for us. Scores below 70. That represents the lowest 2%. Those are scores that are on the extreme left-hand side of that bell curve. This is the lowest 2%. A lot of times, primarily we define aberrant functioning based on that bell curve. If a person's scores are falling on those tails, they either have way too much of something or not nearly enough of something. From an intellectual standpoint, that score of 70 is considered, that's the number that we're looking for to determine if a person has met part of the criteria for an intellectual disability. So let's talk about standard error here for a minute. So standard error of measurement is the extent that all tests of mental ability, if it's reading, if it's impulse control, if it's memory, intelligence, every test in the market has a certain degree of error associated with it. And this is true for medical tests as well. So it's not just a phenomenon of mental measurement. So every score that we have on a standardized test is a combination of the person's true score plus or minus any error. I think it's going to show up as equal or minus error on yours, but that should be plus or minus error, okay? So what this means is that we use tests that are well-normed, well-standardized. Those tests will give us a very similar score time after time administered to the same person. Now, where does the error come in? This comes in for administration, from the test, from the administrator, over encouragement, giving them too much feedback, giving suggestions, scoring errors, and so forth. So what winds up happening is that the error associated with our testing is predictable, just like we mentioned a moment ago with the standard deviation. So the standard error measurement is nothing more than the standard deviation of the error scores. So let's go back to the archery sample. If I have I build two bows. One is a better bow than the other one. I spent much more time on it, and I use some sort of mechanical device to shoot an arrow. I would expect that the more expensive bow that I built would hit closer to the bullseye each time. Okay? And the cheaper bow, it's going to throw arrows more around that bullseye. Okay? So I've got to have a great test and have a mediocre test. My great test is going to give me tighter scores, more consistent scores, more reliable scores than the cheaper test or the cheaper bow. But when I pick those bows up and then I shoot them myself, then there's other errors that come into play here. It could be problems with the wind. It could be how I'm holding the string. It could be how I'm breathing when I release the arrow. That's the error associated with our standard error, okay? That's the user error, okay? That's what I'm getting at here. So that error is normally distributed and it's predictable. Now, our standard error of measurement forms the confidence band within which a person's true score will fall a certain percentage of the time. So those of you, if you read enough psych reports, you see that a score will often be expressed as 73 with a 90% confidence band of 68 to 78, something like this. So the standard error forms that confidence band within which that person's true score will fall 90% of the time, or 68% of the time. Most schools, most psychologists use that 90% confidence band. Now, important thing here, we can use standard error of measurement sparingly to help determine eligibility in certain cases. Okay. So let me give you an example here of our standard error of measurement. The standard error of measurement from almost all IQ, achievement, and adaptive behavior tests is plus or minus 3 points. For almost all tests on the market, it's plus or minus 3 points. This is because most all tests out there have all the instruments that we use in schools and in mental health and in clinics and hospitals. They're all very well normed, and they have great reliability and great validity. Now, here's an important point that I need to make sure that I get across here, is when we're dealing with our confidence bands and the standard error measurement. So if we're going to use the standard error of measurement to determine if a person might be eligible for services, we can only use one standard error measurement, which is plus or minus 3 points. That is different from a confidence band, which is typically much wider. A 90% confidence band could be plus or minus 6 points, whereas a standard error measurement is only plus or minus 3 points. Why is this important? Because if you have a person, for example, here with Julio, if his IQ is 71, we can use the standard error measurement to help determine eligibility. That would get his score down to 69. So we could say his score would range from 69 up to 75, okay? That's one standard error measurement. That's 3 points below, 3 points above. That's not the same as a confidence band. When I started practicing, there were people in schools that confused the two, and they would take a child score who had a score of 79 or 80 on an IQ test, and then they would use the 90% confidence band, which could be plus or minus 8 or 9 points. So they were taking kids with intellectual ability scores in the high 70s and making them eligible for services for kids with intellectual disabilities. So they had confused confidence band and standard error measurement. Those two different things here. So in practice, keep in mind your standard error measurement is 3 points, plus or minus, okay? if we look at Julio, let me give you, this is an example of when you should not use standard error of measurement. So his overall IQ is 71. His verbal reasoning abilities are 65. That's 2 standard deviations below. His perceptual organizational abilities are 80. That's nonverbal reasoning. Working memory, 63. Processing speed, 77. Now, although his overall IQ is 71, it generally would be inappropriate to use standard error measurement because of the degree of scatter among his scores. His verbal comprehension score is 65. That's up to first percentile. But his perceptual reasoning is 80. That's in the low average range. Big discrepancy here. So typically, we would not use standard error measurement in this case because of the degree of scatter. Now, conversely, if his verbal comprehension score was 65, perceptual organizational score was 71, working memory 63, processing speed is 70, then it would be an easier sell to make employ the standard error of measurement. But the degree of scatter among test scores we have to take into account. Too much scatter should not be using the standard error of measurement. So, shift gears here for a minute. We're going to look at screening tests versus more diagnostic tests. So we compared and contrasted Criterion reference tests with norm reference tests. Now we're looking at screening tests versus norm reference tests, okay? So screening tests are these brief assessments designed to tell us which kids might be at risk for certain disorders or conditions, which kids might be eligible for certain types of programming, for example, for counseling and for giftedness, who might be eligible for remediation versus through response intervention, or who might need a more comprehensive evaluation, okay? So schools use screening tests routinely. So for depression, ADHD, in older adult populations, substance abuse, and so forth. So these tests are typically, they're very short, they're easily administered, and it doesn't take a lot of training to administer these things. Some of them are group administered, some are multiple choice. Normally there's minimal training required, and there's really no credential that needs to be used. So paraprofessionals will use these screening tests. So in application, if we're talking about schools, clinics, hospitals, private practice settings, screening tests are part of a two-step process. The screening tells us if a person needs to be evaluated further, and if they do, then we do the more norm reference or individually administered tests at that point. Now, what I have seen over the years is that some people, some psychologists, like to use screening tests as diagnostic tests, and that's inappropriate to do that, okay? So a screening test gives us a measure, more of a narrow band measure of functioning, for example, attention, problem with mood, word reading, verbal expression, and our diagnostic tests are much broader in terms of what they're measuring. So again, I mentioned that can be group or computer administered, typically a multiple choice format because it makes scoring pretty easy. Okay, doesn't require a lot of training, but it's an important first step in determining which kids need to be, or which adults need to be seen for more comprehensive testing. Right. So some samples of some cognitive screeners would be the Kaufman Brief Intelligence Test, or the K-BIT, and I think we're on the K-BIT 3 at this point. This is a 2 to 4 subtest measure. It takes maybe 20 minutes. Takes a minimum amount of training. The SATA is another one, the Scholastic Abilities Test for adults. There's the WACI, the Wechsler Abbreviated Scale of Intelligence, the Shipley. So there's a number of these tests that measure very quickly a narrow band of abilities. But if a person scores low on these, then follow-up testing could be conducted with your school psychologist or with your clinical site at that point. So some sample academic screeners. The RAT, the Wide Range Achievement Test. I think we're on the 5th or 6th edition to this at this point. A lot of times people like to use this as a diagnostic instrument, but it's a screener because it's quick. Nelson-Denny is another one. The curriculum-based assessments that are used in schools, and then your SATA, again, the Scholastic Abilities Test for adults. So academic screeners, give me just a moment here. I just had a question that came in. I'll get to here shortly. All right. So academic screeners often measure low level of basic academic skills like word identification, spelling, or just straight math, paper and pencil math calculation. That those screeners typically do not measure any academic comprehension or the application of any skills. So, for example, a math screener might ask the question, what is 12 plus 7? Whereas a math reasoning task on a more comprehensive test would ask a question like, Juan has 10 friends and 20 hot dogs. If they all wanted to have the same number of hot dogs, how many should each person get? Okay. Okay. So diagnostic tests, like our standardized tests, give us much more detailed evaluation of a person's normative and personal strengths and weaknesses across several areas. They're designed to diagnose conditions and establish eligibility. We've talked about that. And they're typically better normed. There's more people involved in the norming. There's also our diagnostic tests. They have a number of different subtests that they're all designed to measure a similar construct. So it gives us it allows for more comprehensive analysis of scores. For example, between a person's ability to express themselves, their understanding of words, ability to understand what people are saying to them, and their ability to solve problems that they see. So a difference between verbal reasoning versus visual reasoning. Okay? Our screening tests typically measure low-level skills, whereas your diagnostic tests measure low-level and higher-level skills. And then sometimes fluency, how quickly they're able to solve different problems. So we see screening tests used in clinics, in hospitals, in schools, fairly frequently. Normally, when a person is using a diagnostic test, it's those would be administered by school psychologists or school counselors that have very specific graduate level training that is designed specifically to teach them how to administer and interpret tests and how to make sure that they're not misinterpreting tests versus your screening tests that require a minimum level of training. Normally an undergraduate level person could be trained to do the screening test. And it's important that we have folks that are trained to do that because it's a much more efficient use of everyone's time. So, sample diagnostic cognitive tests, the ones that you'll see most commonly with adults would be the WAIS 4, that's the Wechsler Adult Intelligence Scale, 4th edition. This is for ages 16 to 89. The unit is the Universal Nonverbal Intelligence Test. We see that being used some. The WISC-5, the Wechsler Intelligence Scale for children, is for ages 6 to 16, 11. I use that one very frequently in my practice. Same thing with the Kaufman Assessment Battery for children, the KBC-2. I use that one frequently. The Woodcock Cognitive, that's more of a second-tier IQ test. And the Stanford Binet, although it's still on the market, you don't see many people using that. So typically what you're going to see for your clientele that you're working with through Department of Mental Health would be the WAIS, maybe an old WISC, might see a Woodcock. Some sample achievement tests. We have the Woodcock-Johnson 4 Test of Achievement. That's really a pretty good instrument. Measures a wide range of reading, writing, and math skills. The Wechsler Individual Achievement Test, 3rd edition, is another great measure. The Kaufman Test of Educational Achievement. 3 really good diagnostic achievement tests. So right now, our gold standard, there's about 3 good IQ tests and 3 academic achievement tests that we can use for adults and for children. Now, we talk about adaptive. So some adaptive tests, we haven't talked about that in depth here, but we'll go to that here in just a minute. So some sample diagnostic adaptive tests would be the ABAS, so the Adaptive Behavior Assessment System, and then the Vineland. I use both of these a lot, especially like the Vineland. They're well-normed, well-stratified measures of independent functioning. So let's get more into the proverbial weeds here with the WAIS. So I mentioned earlier, average scores for this test are 90 to 109. This test gives us an overall IQ, the full scale IQ. That's a composite of 10 individual subtests. These subtests take 5 to 7 minutes apiece to administer. So you have the full scale. It also gives us 4 different factors that, when used in combination, can tell us how this person learns different types of information. It tells us how they're able to express their intelligence. Okay, so the Verbal Comprehension Index is there's 3 subtests. Measures verbal reasoning, verbal expression. Perceptual organization, 3 more subtests. This is nonverbal reasoning. Then processing speed and working memory. So here's what our scores look like. 90 to 109, those scores are average. 80 to 89 is low average. 70 to 79 is borderline. It's the lowest 2%. 69 and below those are the scores that we're looking for when we're considering an intellectual disability. So we can look at this graphic here. You can see our full scale is composed of those 4 factors, okay? So if we look at what these things are measuring, your full scale IQ here, seen as a measure of just overall intelligence. And again, it's just a compilation of 10 subtests, but it's considered to be the best indicator of a wide range of outcomes, such as employment, mental health, being able to adapt to the environment, educational achievement. Now, verbal comprehension, this is a measure of the ability to retrieve and apply verbal knowledge. This is a compilation of how much you've learned over the years, how well you're able to express yourself, how well you're able to understand what other people are saying to you, okay? Now, bear in mind, years ago, but around the 1920s and earlier, in that general era, most IQ tests only give you 1 score. And those tests, for the most part, were discriminatory against a wide range of people. They were not very well designed. They had limited stratification in their norming, and scores ranged wildly between people of white folks, African Americans. The tests now are much, much better designed, primarily because of the advent of computers. We're able to use more computer modeling. But the tests measure a wider range of intellectual abilities. So for the WACE, we have the full scale, but then we have our verbal reasoning index, and we have the perceptual reasoning index, which is mostly visual problem solving, being able to use inductive and deductive reasoning, solve novel problems, linking visual information to abstract concepts, okay? Think of people who are really good engineers, that are tradespeople. Those folks tend to have very well developed perceptual organization abilities. They're able to think visually and solve those visual problems. Working memory, this is how much information that you can hold in your mind for a very short period of time and then manipulate it, do something with it. So this is a very good measure of attention and concentration. Children and adults who have problems with ADHD tend to struggle with working memory. So I'll give you a good example of what a working memory task might be, would be to count backward from 99 by sevens. So try to do that. That is very tough to do because you're required to not only pull up the numbers in your head, but then you're having to apply some math. So you're having to keep several things operating at the same time. It's very difficult to do. So children and adults with ADHD struggle with that piece of it. Okay? Let's see. So, processing speed is the next component of the Wechsler scales, and this is simply this is a measure of decision-making speed. It requires eye-hand coordination. Those require visual memory and concentration. being able to scan information, a visual array very quickly. The two most important components of the Wechsler scales will be the verbal reasoning, verbal comprehension index, and the perceptual organizational index. Let me see. I have a question here. Let me see what I can read here. Yeah, there's a question that where a psychologist in the past has used a screening test and they're trying to use it as a diagnostic test. Most of your screening tests, they have limited standardization qualities, and they aren't to be used for diagnostic purposes because that's not why they were developed. They were used just for screening, just to see who needed further testing, not to determine who should be eligible for services. Some psychologists like the screening tests because they're fast and they're very easy to administer, and they can have their assistant do it. That's inappropriate for most all applications, especially in schools for mental health. And it's probably an issue of the psychologist not having time to do it, or maybe they just don't know better. I'm sure I don't know. But a diagnostic test is qualitatively different from a screening test. So the Woodcock-Johnson test of abilities, this instrument has actually been around since the 80s. And what the Woodcock-Johnson series, they also have a full-scale IQ, but they call it GFGC. So it's just a combination of verbal abilities and fluid reasoning abilities. The concepts between this and the WACE are the same. They just have a different name to it. So GFGC for the Woodcock is the same thing as your full-scale IQ for a WACE. Comprehension knowledge on the Woodcock is the same thing as verbal comprehension on the WACE. Fluid reasoning on the Woodcock is the same as perceptual organization on the WACE. Okay, this is just a different name, different terminology. Now that GFGC, that's just 4 subtests. Typically is not used for intellectual disability diagnoses. So to do that, you need to administer 10 subtests. You need 10 subtests in order to get a good sense about this person's overall ability. But the Woodcock, for me, and I helped Norm the 3rd edition on this, and that took several years. The Woodcock is a very good measure of learning disabilities. It's typically not the best measure for intellectual disabilities. I just won't use this for intellectual disabilities. So I'm not going to go through the different factors that's being measured here. That can be fairly boring. We'll talk about some of the more popular achievement tests. Give me a moment here. Okay, so we touched on these a moment ago when we were comparing screening tests versus diagnostic tests. These are, your best measures of academic achievement for diagnostic purposes. So our comprehensive or diagnostic achievement tests, they measure a wider range of academic skills, not only basic reading, being able to identify individual words out of context, but they also measure reading comprehension, or the ability to understand what you're reading. They can measure decoding. They can measure reading speed. They can measure math reasoning, math calculation speed, paper and pencil math. So these tests, the Woodcock-Johnson achievement, for example, takes about an hour to administer. Very good test, and because it has a mean of 100 and standard deviation of 15, it's easy to compare scores on it back to the WISC, back to the WACE. Okay. So average scores on most academic tests are 90 to 109. That's for the Wechsler scales. The 90 to 110 is average for your Woodcock-Johnson, and then 85 to 115 for the KTEA, the Kaufman tests. Okay. Let's talk about adaptive behavior here for a minute. Adaptive behavior is used in concert with measures of intelligence to help us determine if a person has an intellectual disability or not. So adaptive behavior is the extent that a person is able to meet the expectations in their day-to-day lives in terms of self-help skills like bathing and dressing and feeding, social skills, being able to control their temper, being able to communicate effectively, being able to navigate the school and community environment. Now, these things are learned, okay? Now, compare that to intellectual ability. That's a combination of both learning and genetic endowment, okay? So adaptive behavior is learned behavior. Intelligence is a combination of what a person has learned and what they were blessed with from the good Lord, just to put it, just to be frank. Here's the important piece about adaptive behavior. The tests that we use for adaptive behavior require us to ask questions from an informant. So someone that knows the individual being tested quite well. Normally this is a parent and or a teacher, okay? So with adaptive behavior testing, we're asking other people the extent that this person is able to brush their teeth independently, get dressed independently, control their own behavior, and so forth. With intelligence testing, we're doing this one-on-one with the individual, okay? Here's an important point with adaptive behavior. The biggest errors that I see in application with adaptive behavior is that the person who is completing the form confuses can do versus does do, okay? So the tests, the adaptive behavior tests, hinge upon the extent that a person actually does something. I'll give you an example here in a minute. Does something without a reminder versus can do. So, for example, if my son, if I have to remind him every Friday to take the garbage down, then he's not going to score as high on an adaptive measure as if versus someone else who does that independently. They know that that's their job. So on Fridays, they take the trash down to the curb without having been reminded. Here's another piece. So, can I wash clothes? I can. Do I wash clothes? No. Now, I got out of washing clothes years ago because I found out that, one, I didn't like doing it, and two, if you put something red in a washing machine with a bunch of whites, that's going to ruin a bunch of clothes, and it doesn't take long before someone tells you, please do not wash clothes ever again. So, can I wash clothes? I can. Do I? I don't. So I'm not going to score as high on that aspect of the adaptive behavior. A lot of the tests I see in schools, the school psychologist or the school counselor will simply give that form to a parent and ask the parent to complete it and bring it back. Literally 95 times out of 100, parents misunderstand how to complete those adaptive behavior tests, and they wind up the kiddo scores much higher than they should have scored. So one of the items might be brushes his teeth. Well, he can brush his teeth, but I have to remind him and prompt him, but they'll still give him full credit because he can do it. He just chooses not to do it, or he doesn't do it. Okay? So that's two different things. Can do versus does do. It's a very important concept. So if you have a person whose measured intellectual ability is 56 and then their adaptive behaviors in the 70s or 80s, there's a very good chance that that informant misinterpreted those test items. So an example of good adaptive behavior test, and there's a number of these out here. There's the Vineland, average scores on the Vineland are 86 to 114. This is appropriate for ages birth through 90 plus. There's teacher forms, there's parent forms, and also provides a measure of maladaptive behavior, like problems with mood or impulse control or running away. So the structure of the ABAS looks like this, where the ABC, or the adaptive behavior composite, is composed of four different, actually three different scales: communication, daily living, and socialization. Motor skills are used, but they don't contribute. That score does not contribute to the composite here. So our different domains for the ABAS. The communication domain measures receptive language, ability to understand what people are saying to you. Expressive language, being able to use words appropriately. And then written communication. Daily living, self-sufficiency and personal self-help skills, dressing, bathing, hygiene, performing household tasks, cooking. And of course, all of these things are norm referenced, so an 8-year-old is only going to be compared to other 8-year-olds, okay? A 15-year-old is only going to be compared to other 15-year-olds. And then your socialization domain is the effectiveness in relating to others, being able to start and end conversations, being able to maintain self-control. And then the ABAS, average scores on this measure, 90 to 109. This is similar in terms of the norms. It's normed on ages birth through 89. There's a teacher, a caregiver, and various other adult forms on this. An adaptive behavior will take about 30 minutes to administer. So this is what the structure of the ABAS looks like. So there's a question on the chat here. Let me read this real quick. Oh, function. So the difference in, is there a difference in the functionality versus adaptability in assessing for skills in a situation where it's can do versus does do? Well, the main thing here, these adaptive tests are norm referenced, and they are normed based on does do versus can do. And so if the person rating the consumer, the client, misinterprets those forms and interprets those as a can do, then it's going to make the scores much higher than if they had used does do. That could prevent the person from receiving services that they might otherwise have been eligible for. Okay? I'll go back again, like one more example. Whenever, so I've got a wife and two children, and when they were growing up, my children, when my wife was around, their adaptive abilities actually were quite low, because if they were hungry, they say, "Mom, I'm hungry." And of course, she would jump up and just, "Well, what would you like to eat, sweetie? I can go get that for you." Well, they were completely helpless. Now, if she had to go out of town for a training and they were left with me, they would say, "Dad, I'm hungry." I say, "Do you know where the refrigerator is? Then help yourself. Do you know where the forks are? Okay, go knock yourself out." So their adaptive ability would immediately increase, just simply because of the changes in the environment. So that's one of the factors we have to sort of keep in mind here when we're measuring adaptive functioning. We will see differences between raters on this. But back to this other point, it's important to make sure that we're basing our scores on a can do, that on a does do versus a can do. Okay? So here's our domains from the ABAS, conceptual, practical, social. They're virtually identical to what we saw with the Vineland. Okay, so they're measuring the same constructs here. Okay. So, got a few more slides I want to go through here. Just a quick review of intellectual disabilities. So this is the term used in the Diagnostic and Statistical Manual, 5th edition. We use intellectual disabilities to cover what used to be called mental retardation. Since Rose's Law, which was signed into effect under Barack Obama, it essentially, this allows us, for lack of a better word, for using mental retardation. That's become a pejorative for a lot of people. So intellectual disabilities is the current nomenclature that we use. So this is diagnosed whenever a person's intellectual and adaptive behavior are 2 standard deviation units below the mean. That is when the IQ and the adaptive are below 70. Again, we can use a 3-point standard error of measurement. So if you have a score of 72 on the IQ, a score of 71 on the adaptive, you can use the 3-point standard error measurement and make the person eligible for services. Obviously, any decisions along these lines should be a team decision. Okay. Another aspect of the condition of the diagnosis is that it must occur during the developmental period, that is during childhood. So this keeps us from, if someone has a brain injury, for example, and now their intellectual ability is measured in the mid-60s, we can't say that they have an intellectual disability. We'd say that they have a traumatic brain injury or a neurocognitive disorder, okay? So other things that we have to rule out are other things here that are not an intellectual disability, include brain tumors, brain injuries, toxicity, near drowning, for example, poisonings, various neurological conditions. So, the DSM, the Diagnostic and Statistical Manual that most all clinical psychologists use, recognizes 4 levels of intellectual disabilities. There's mild, moderate, severe, profound. So some of the things that I'll just point out is for individuals with mild intellectual disabilities, their approximated mental ages in adults is between, say, 8 and 11. So they typically top out. They function around second, third, fourth grade level at this point, or third, fourth, fifth grade level. Folks with moderate intellectual disabilities, their approximate mental ages in adults is, between 5 and 7, and then you see where it just kind of goes down from there. I will say that the terminology, if we're using mild, moderate, severe, profound, that's based on the adaptive test scores and not just the IQ. So it's a combination, depending upon if it's mild, moderate, severe. That stems from the score on the adaptive. But your overall IQ still has to be below 70. So some of the etiology, I just put this in here just to kind of point out that there's a wide range of conditions that are associated with intellectual disabilities. And I'm not obviously going to go through these. Frankly, I don't know how to pronounce most of them, so I don't want to embarrass myself here. There's a lot of factors. There's perinatal factors. Talk about mild intellectual disabilities here. Now, again, these are folks whose measured IQ and adaptive is 55 to 69 or so, okay? So a lot of these individuals, there's a big family connection here. In other words, if the child has a mild intellectual disability, there's a better than average chance that one or both parents is going to have a mild intellectual disability. This is one of the reasons why I do not like sending home a measure of adaptive behavior with a kid to have their parent fill it out, because I'm not sure if they're going to understand it and return it in any sort of interpretable fashion. So I'd rather do those face-to-face or over the phone with the parent. So this represents 85% of all individuals with intellectual disabilities. Now we're already looking at this lowest 2%. So the 85% of that lowest 2 are folks with mild intellectual disabilities. So it's a combination of both genetic endowment and poor environmental conditions, access to intellectual stimulation, reading, medical care, food, so forth and so on. Typically, it's non-organic etiologies. I went the wrong way. Most of the limitations that you see with people with mild intellectual disabilities, it manifests during the school, and it may not be as quite as apparent as an adult. In general, talking generalities here, most individuals with mild intellectual disability, they tend to be externally motivated. They have a mild to moderate lag in behavioral development, interpersonal functioning. And most interventions are designed to teach more functional academic skills, vocational skills. What am I doing? I'm making it larger. I'm going to do that. Okay, let's go to all right. So if we talk about moderate, severe, profound, so individuals with scores, with intellectual scores, adaptive scores in this range, and usually these rates are equal across ethnic groups and socioeconomic levels. Okay? Put another way, that your sibling IQs are normally average, parents' IQ are normally average. So this is a much smaller percentage of all the people with an intellectual disability. It's only 15%. Most of the problems associated with most of the etiology here with moderate, severe, profound is due to single gene defects like Down syndrome, various ranges of chromosomal abnormalities like Turner's, and you also see brain malformations. Okay, so there are qualitative differences between mild levels and then your moderate, severe, profound. Hang on, let's try to fix this. Neil, can you? Okay. All right. Yeah, so let's do a couple of case studies here. Let's talk about Malia. So what I want to point out, so Malia has a comprehensive WACE IQ of 72. She has a verbal comprehension of 64, perceptual reasoning of 86, which is low average, working memory of 67, which is extremely low, processing speed score 79, which is borderline. Okay. Now, independent functioning, her adaptive composite is 78, communication is 66, daily living, self-help skills 74, socialization 83. Now, if we look just at these scores, one could try to make the case of using a standard error measurement for the full scale. That would pull her score down to 69. But even with the standard error measurement, her score of 78 on the adaptive composite is not going to be low enough. So rather than looking at this profile of scores from the standpoint of could this be an intellectual disability, let's look at the range of scores. So her nonverbal reasoning is actually low average. Her social abilities, socialization, is low average. Her communication is low, but she does have some strengths here. Okay, so this person would not meet eligibility criteria for an intellectual disability. It would be inappropriate to do that. With standard error measurement, the IQ would be low enough, but still that leaves us 86. That's way too high for us to consider even using standard error measurement. The Vineland, those scores range from extremely low all the way to low average. And even with the standard error, that 78 is not going to be low enough. So Malia, although she obviously needs services, accommodations of some sort, she's not going to be eligible for an intellectual disability. So let's look at Oscar here. Now his scores are much more uniform. So here we have a full scale of 69. That's low enough. Verbal 72, nonverbal is 61, working memory processing speed. You see how all the scores now are all around the second percentile and lower. Now, his adaptive composite 72, but here we could use the standard error measurement, and that would get his overall adaptive score down below 2 standard deviations. So this is a case with Oscar where using the standard error measurement would be much more appropriate. Let's look at Lexus here. Here we have a WACE IQ of 55, or verbals 64, nonverbal of 50. All of our scores are ranging, from 50 up to 71 on the IQ, and then from 48 up to 72 on the Vineland. Now, this is more of a case of a moderate intellectual disability. So moderate intellectual disabilities are when IQ scores are between, and adaptive, are between 40 and 55. So here again, we could use the standard error of measurement and apply it to the 55 and apply it to the adaptive composite of 56, and that gets Lexus' score down into the moderate range, okay? Now, got a couple of questions here. Let's see what these are. There's a question about sex education for folks with moderate, consumers with moderate disabilities. That's going to be out of this. I'm not going to be able to help you with. That would take someone with much more hands-on day-to-day interventions. It's a darn good question. I'm just not able to answer that one. My apologies. Had another question of what happens if you have an individual who's had multiple IQ tests. Now, sometimes you see this when a person is consistently, they may have scores of 69, 72, 70, 71. What happens is if you get a bunch of scores, 3 or 4 scores, they're all falling in the low 70s, there's a thing called regression to the mean that could possibly account for the person's scores actually getting higher over time. There's also a practice effect. So when I see a child or an adult who's had 5 or 6 different IQ tests, then I start to really doubt the veracity and accuracy of those scores because of the practice effect, because of the fact that you have multiple scores, multiple tests, and those scores will actually could overestimate that person's true IQ. Then I'll never know, too, if someone is fishing, if they're fishing to try to get make a person eligible. Not saying that the person doesn't need services, but saying that the eligibility could be questionable if they've been tested multiple times. So at this point, I am through with what I wanted to cover. I will give you an opportunity starting Monday when I will be back. Feel free to email me. It'd be a lot easier. Feel free to email me at mdunham@murraystate.edu, and I will get back with you. I have a private practice in West Kentucky. I see children for abuse and neglect cases, some child custody, and I have a clinic on campus where I see a lot of children and adults. Also do quite a bit of work for vocational rehab. So I'll be more than happy to try to answer any questions that you have related to this, to the material that we covered today. So at this point, I appreciate your cooperation, and I hope that you have a wonderful weekend.